I'm Raleigh Watts, and I'm the Executive Director of Country Doctor Community Health Centers, which also includes Carolyn Downs Clinic here in Seattle.
And I'm Rich Kovar. I work with Raleigh and Sarah. I'm friends, essentially, and do full spectrum family practice at our community health center.
Well, I've known Rich for more than 30 years. Rich is a family practice doc, Washington University, D.C. That's where you went to medical school and did your residency in Oregon Health Sciences. So Rich also has the distinction of being named the Outstanding Family Physician by the American Academy of Family Practice a few years ago in the whole country. And I know Rich is a man of very strong opinions, which is good, most of the time, right?
Yeah, absolutely.
And got to know Raleigh a couple of years ago. Raleigh has an extensive background in domestic and international health, particularly around the AIDS problem for many, many years, and was president of the board of Country Doctor before he assumed the role of executive director a couple of years ago. What we're going to do is Rich and Raleigh are going to talk a little bit about Country Doctor and possible problems that could arise with Medicare for All, and then we'll have a good discussion about any concerns they might have.
I'll just start out by saying thanks to all of you on the PNHP board for slogging through these complicated and important issues month after month, meeting after meeting, hearing after hearing. Really good work. The world is going to be thankful when this all comes to fruition, and we're thankful today.
The U.S. will.
Yes. David said that we would talk about problems. I'm going to talk about opportunities. Rich might talk about problems. But we thought we would just say a little bit about why this is an important issue to us, maybe one or two sentences each, and then just put some facts and pictures on the table about community health centers in the United States in general, just to make sure everybody has the same basic knowledge about community health centers, and using our community health centers here in central Seattle, just a half mile away, as an example. And then talk about the future and where we think community health centers are going and can go and can be part of Medicare for All in the future, so some opportunities. So, Rich, just in a sentence or two, why is it important for you to be here tonight and tell the story?
I think it's important. I actually, I came to this town actually 15 years before David Springer over here was involved in getting the Country Doctor Community Health Center started. And I'm deeply indebted to you. He's kind of an icon, famous, and it's amazing how the stories about him still keep going. But all this builds on itself, right? I came here and I think I got involved in what was the original Healthcare for All. It was the original one there in the 1986 kind of thing, where we were trying to, in Jim Krieger's attic, we were trying to figure out where do we go for this? How do we advocate for universal health care? It is the grail. We all are on the same page there, and everybody needs to be in, nobody out. But we also known right all from the start that a card doesn't do it. The real challenges that face people in our society who are vulnerable populations, you just can't take care of them with just a card. So you need a system of health care, which gets forgotten about when we talk about paying for it. I was there on ground floor day one when we created a system for managed care in the state as a response to a national movement towards managed care, and we came up with a solution here that created managed care that was going to benefit low-income folk in our state. So, and it goes on and on. I've seen everything happen in these 30 years, and it goes around. And I think, and I could talk about the problems and will, but I still, at the end of the day, I still believe in that Winston Churchill adage that actually he never said that you can always trust Americans to do the right thing, especially after they've exhausted every other possibility. So we are getting there. If any of you have never picked up the book Factfulness, just write that down and do read it at these troubling times where it seems like the end of the world and we're never going to survive all this. It is that ray of hope. It is recognizing recognizing how far we've come as a local community, as a state, as a country, and as a world, in so many ways have gotten better. And I think we need to remind ourselves of that as we go into this kind of reform and figure out where we're going to go with universal health care and where the Jayapal and Sanders efforts are going to end up compromised too at some point. We've got to keep this as the optimism and the hope alive. This is not that desperate because we are so much better off. None of us would have wanted to be living in a vulnerable population in the 1950s. So I approach it from an optimistic point of view. The fun thing about being invited here, and I'm really grateful for that because it got me to read the bills. So I read Bernie's bill, and I read Jayapal, the House bill, and I looked at it, and I looked at it kind of from a stepping back, and then I looked at it from a self-interest point of view. Where are the opportunities? And I've seen this happen. I know how the legislative process works. It's a process. It's like making salami. And it's going to have a better iteration next year because, I mean, that's my opinion. And so I think what Raleigh and I can perhaps do is inspire some of us or you to think about how we can communicate with our elected representative to make it even better, because the heart's in the right place. She's absolutely right. The goal is there. The grail is clear. But there are some real landmines along the way, and I'd like to, hopefully we can have a discussion of what some of those might be.
Yeah. For me, the reason why I'm honored to be here tonight and why it's important to me is, first of all, just to say my connection to Country Doctor goes back 25 years, so not as long as Rich's, but I started out as a volunteer, volunteering on the board. And one of the things that drew me as a volunteer is the mission and vision of the organization. So we often hear about organizations' mission, which for Country Doctor, which is a community health center just a little bit away, to provide high-quality care to all, regardless of the ability to pay. But it's the vision that I want to share with you, because the vision is important, and it's been a guiding vision for us for decades. A vision statement is our vision of the future and how our organization sees itself down the road. Our vision is there is universal health coverage, and we are the provider of choice. And I just think that was so clairvoyant when that vision was developed many years ago to where we are today, and I hope that the vision becomes a reality. I had a conversation with David that led to our invitation to come here tonight because of a concern that I had, and I just want to put that on the table first, and then as we share a few things and have a conversation, I'll be able to let go of that. But the concern is that as I read the legislation, and as I go to public hearings, and I met with Representative Jayapal's staff in Washington, D.C. 2 weeks ago, I don't hear a lot about community health centers. And when I do, I hear about them as a payment issue. And from where I sit, community health centers are what universal coverage looks like. We are an exciting picture of the future that's here today. We can help with the transition to get there because we know what it's like, and we can be a key, critical, central part of that future vision. So when I think of global rates or global payments, I worry that, gosh, I don't want us to be seen as a payment mechanism when I think we're actually the picture of the future. Let me just provide a little bit of a context for what community health centers are and how this movement over the past 40 or 50 years has brought where it has brought us today. So across the U.S., 1,400 organizations are community health centers representing 11,000 care delivery sites. So here in Seattle, there are several dozen, but around the country, 11,000 care delivery sites. These are all nonprofit organizations, so operating not-for-profit in healthcare. They're organizations where the board of directors, more than half of the board members of each of these organizations, are patients. So patient-run nonprofit organizations providing primary care. Across America, 28 million patients are served by, or 28 million people are served by community health centers. So 1 in 12 Americans and 1 in 3 low-income Americans gets their care at a community health center. And I'm saying all this because I want us to have a conversation about how we can be in the middle of where we're going. The patients that are served by community health centers are not always easy patients, complex. 91% are low income, 63% very diverse population, 63% racial ethnic minorities. Half of all people on half of the people served at community health centers are people on Medicaid, and community health centers serve over 1.5 million homeless people throughout America. Innovation, 90% of community health centers across America provide behavioral health on-site in addition to primary care. A third of community health centers are doing innovations today in telemedicine. We are with specialty consults. And I think the interesting thing, as I've come to learn about community health centers, is investing in primary care saves money overall in specialty, hospital, emergency room care. We know that. Community health centers have that data. So the cost of serving people who are on Medicaid at community health centers versus serving people on Medicaid at non-community health centers, 24% lower. So community health centers have a lower cost model per Medicaid data. And I learned recently, you can tell I'm pumped up because I was at a conference of community health center directors in Washington, D.C., but every dollar invested in community health centers saves $4 overall. And the Office of Management of Budget reported at the conference I was at that of all of the federal programs they evaluate, the federal funding that goes to the Bureau of Primary Health Care that supports community health centers is the best bang for the buck, the best return on investment of any U.S. tax investment they've seen. So I think it's kind of an impressive thing. Let me just bring it home a little bit. Here in King County, more than half of low-income people here in King County get their care at community health centers. There are 6 community health center networks in King County. You know them. They're Neighbor Care, CMAR, Health Point, International Community Health Services, Seattle Indian Health Board, and then Country Doctor and Carolyn Downs, where we work, Country Doctor Community Health Centers. And those 6 represent about 18 or 19 care sites because each of those organizations has multiple sites. I want to just paint a little bit of a picture of our organization in case that helps with the discussion later on. We have 3 sites, 2 full-spectrum primary care sites on Yesler, the Carolyn Downs site, founded by the Seattle Black Panther Party in 1969. And then up on Capitol Hill on 19th Avenue, the Country Doctor Clinic, 1971, founded by activists involved in anti-capitalist and anti-war efforts. And then a 3rd site right here in this building, just over on 16th Avenue, that is a partnership we have with Swedish to provide walk-in care. And we've placed our walk-in clinic right next door to Swedish's emergency department. So people can self-triage. There's a sign outside that will help people know they don't have to go to the emergency room in the evening or on weekends when we're open if they need care that could easily be dealt with at a walk-in primary care clinic. We serve about 20,000 primary care patients through about 70,000 visits a year. And our population reflects some of the national data I shared. 2/3 of our patients are below 200% of the federal poverty level. And you know, we're right here in central Seattle, and people ask me all the time, gosh, I thought everybody in Seattle's wealthy now. Why are there community clinics serving low-income people here in the heart of Seattle? And you know, I'm hearing laughter, so I'm preaching to the choir, but a couple of factors are at play. And first of all, while there has been tremendous demographic change in Seattle, people who have moved away, gentrified away, come back here for healthcare. The central area and Capitol Hill are places where people identify community-wise for different services they need. But more important, about half of our patients still come from the central Seattle area. And many people living here have no resources at all. They're doubled up in people's couches. They're living in public housing, scraping together jobs. So I think when we were started, we might have served a population that included more working class families. And while we still do that, we have more people with no resources at all who are right here in Seattle living out the wealth disparity that we see before our eyes. We provide care in 36 different languages. About 1 in 7 of our patients prefers to receive their care in a different language than English. And looking just briefly at our revenue today, about half of our revenue comes from our ability to bill Medicaid or our ability to bill private insurance for our patients that have qualified health plans or employer plans, as some do. But the other half comes from grants and from donations and from activities that we can do to generate revenue. So interesting financing model. We sort of scrape together what we can. We have about 200 staff, several of whom are here in this room, as you heard. And like I said, about 20,000 ongoing primary care patients here in the Seattle area. So that's a little bit about just sort of the national picture of this giant community health center movement, 1 in 12 Americans getting their care there, and then here in Seattle who we serve. And I think I'll just say I don't want our low-income patients to get lost in universal coverage. And I wouldn't want a belief if we just make sure that there are payment mechanisms out there that all people will get care, to lose some of the incredible innovation that we see at our community health centers. And Rich, do you want to just talk about some of our programs and some of our patients? And
Sure, I think that was an awesome introduction to what we do. I think I would add a few, just to kind of, I think this is a point where you pick up a pencil and you start doing some arithmetic. It's not even like math, it's just regular arithmetic. But not only did we take care of 1 out of 12 people in this country, we take care of 1 out of 10 children.
Yeah.
This is our network. 1 out of 6 people one out of 5 people who live in rural America get their care at a community health center. And there's a lot of statistics when you dig that down, 1 out of 6 in Medicaid. And so this is a network, as Raleigh said, yep.
Somebody online asked if you could use the microphone.
Sure. Oh, pass it around.
Good.
So,
Put it on.
but the reality is 11,000 sites with actually a fair amount of growth since the Affordable Care Act, which was a godsend for us. It was godsend for America. And 1 out of, and so when you add up those 11,000 sites, you just do the math, they're in all 50 states and territories. There are very few counties. There are some counties without a community health center, but you don't have to, you go to the next county and there's one. They're so widely distributed. If you just stop for a moment and think about what we think of other primary healthcare network in America, there's nothing. You can throw out a word with the K word, Kaiser. I mean, they're cool. I like Kaiser. They even have some semblance of community input into the care they provide. But they're like they're in the Northwest in Canada. That's it. And a few other places in the country. You could throw out the Mayo Clinic, a very discreet, limited entity from a geological, geopolitical point of view. So this is an enormous network of care that's built for all the right reasons. And I'm trying to put some language out here because this is where our elected representatives need to start using this language. There are 4 principles that guide our vision. One is that we serve low-income, vulnerable populations. Number 2 is that we have geographical distribution. The other, and this is what Congress has mandated, that we take care of people regardless of ability to pay, and very importantly, we call enabling services or wraparound services. So that's what Raleigh was talking about. I'm just a regular doctor. I'm not smarter than any other doctors or healthcare providers, except that I know that you can't take care of vulnerable populations by yourself. We cannot do that. It is far too complicated. It is naive and the height of arrogance to think that primary care providers, for example, can be the sole provider for vulnerable populations who are mentally ill, homeless, HIV infected, undocumented. I could go on and on. The list goes 30, 40 categories, opiate use disorder, etc. So we've built a system that has these enabling services with wraparound services. So we take at Country Doctor, we have about 500 people with HIV infection. I can't, and oh, by the way, 2 people have died in the last 12 years of HIV infection, and nobody has, and those 2 people wouldn't take their medicines. That's extraordinary. And I can tell you what happens as a nation without a coordinated system of care, but this is just, it's phenomenal. It's beyond belief. And that's something a little to do with me because I try and stay up, but it's the nurses that provide these wraparound services, our case management that knows how to make sure people have coverage, housing, mental health care, chemical dependency, They just know it. We live it and we breathe it. And you could take opiate use disorder. We've responded to the epidemic by assembling a team with nurses and a coordinator to help people get into treatment for their opiate use disorder. It goes on and on. I love this one. Sarah and I deliver babies. Sarah, what was the last low-income baby you know in our practice? Low birth weight, I'm sorry.
Oh.
Yeah, if any, and this is a multicultural, multiracial, multi-ethnic, low-income obstetrical population, that we cannot name a low-income baby. Low birth rate, sorry. Well, and it's interesting, because I would refer any of you to what started that strong national dialogue about it. You know, a year ago, my daughter pointed that out to me about the African American death rate in African American pregnant women and low-income, low birth weight babies. It's phenomenal. It's bad. As a nation, it's really bad. But when you put it for the right reasons and you get the funding to make it happen, you assemble a system of care. It just doesn't happen. It vanishes. It's better than in the well-insured population. It vanishes. It's not because of Sarah and I. It's because, oh, by the way, everybody at intake gets screened for all kinds of problems by our extraordinary committed nurse. And the social worker meets with everyone. And they all get a nutrition consult. And we get them to the dentist. And where there's no barriers. And we get into mental health. I could go on, but program by program by program. And this is, I like talking about our organization, but if you've seen one community health center, you've seen one community health center, because that fourth pillar, what I really meant to say was, it has that principle built into it, that was what Raleigh mentioned, that more than half of our board, that's by federal statute, receive their health care in our health centers. They sit on our board as volunteers. That is community-oriented primary care. And the COPC, which a number of you will shake your head, because I remember that, what happened to that? That's where it went. It's the last vestige. So it's an extraordinary story, and why in the world we would want to to throw the baby out, well, risk the farm, is the term I would use, by reform that doesn't keep this front and center, not just kind of funded. I'll go into where I see opportunities for improvement, but why we wouldn't want to build this around. It's arrogant, it's self-righteous, but it's also right. And if there is one thing the health centers have failed, the one thing they have, we just have not told our story. I put that on, our national organization there, and there's a good reason for it, because this is, at the end of the day, and I could go through history. I could go from the Social Security Act of 1938 and the amendments to Social Security in Title 18 that got us Medicare and Medicaid, that these health centers have depended on this. They've kept these programs strong and accessible. And we just can't afford to see these important things get weakened for the most vulnerable people in the interest of providing a corridor for everybody. So that's the language. But I'm trying to just inspire a little bit, saying, why would you want to invent something else? And so what happens at a congressional level, I can name on one hand the number of programs. Raleigh knows this because he was just back in DC. I can name on one hand the number of the programs that have broad bipartisan support. Remember that word, bipartisan? It's like gone. Right. But the community health centers are beloved, and woe to any legislator who does not support their community health center anywhere in this country. That's a phenomenal thing. Motivations may be different, might be, a humanitarian thing on the one side, not the other extreme. It's exactly what Raleigh said. $1 spent in the Medicaid program returns $3 to the public. They're cost effective, and that's a good principle. These are tax dollars. So, basically, when we get asked to help our representative rewrite this next year, I think that we can start drilling down on some of the language that we've looked at and suggest how we don't appear as just one acronym of FQHC. I can explain that if there's questions, or Raleigh can. One acronym in a parentheses in either bill combined. I'm sorry. No, I mean, that's it. I was trying to rev everybody.
Yeah. Good. No, I just wanted to say one last thing to conclude, and I'll hand it back to you. But I totally agree with Rich. I think the point that I hope we can discuss tonight is how federally qualified health centers or community health centers, like we're talking about, can be described as innovators, can be described as the center, the primary care example of how the system should be. And I worry that the way the legislation is now, the global rate makes us a payment issue. And a payment issue is not what we are. We are the vision, the example of what universal coverage can look like for the country. I want to provide just kind of a concluding example of one of the things that Rich was talking about in terms of the diversity of programs we have and how our board, made up of patients, provides stewardship. Just 45 minutes ago tonight, I was at a board meeting of our program committee where patient board members sit around and review a 65-page quality report that includes all the different quality measures that we look at that come up after going through different staff committees to the board level. But there's one based on equity that I'm most proud of, and where is it? Along the top are different health quality conditions that we monitor: PAPS tests, good blood pressure control, colon cancer screening, HIV viral load suppression, et cetera. And along the side are various demographics of patients, the payment source or type of insurance that they have, their race, ethnicity, their age, gender. And we compare with red and green whether it's getting better or worse and whether there are any gaps based on any particular demographic groups by the health condition we're looking at. And it's just exciting to me that our patients sit around and monitor the quality of our care and guide us as staff what to do. So my first point is, I think we're more than a payment issue. I think that we're an example of what the future should look like. But the second thing I just want to conclude with is, we know that we're going to be in transition for some time, that Medicare for All won't be 2020, maybe not 2021. It'll take some time to get there. We are what that can look like. I think as community health centers, spokespersons like Representative Jayapal speaking about community health centers, using us as an example, painting the positive picture of what we are, can describe the future that we're going to. So I think we want to talk a little bit in our discussion about what's in the legislation that we'll be at down the road. But I just also want to offer that we can be here along the way, because I'm excited about this model we have, and I think there's an opportunity for us to really be the center of American healthcare in the future. Last words, Rich.
I don't know that it's last words at all. I think, and this is not meant to be disrespectful to any other healthcare system, because, right, I mean, solutions are local, and we should be very proud of a lot of the networks of care that we've put together in our region here. It's extraordinary, but it takes all it takes all hands on deck. Is really it. So we have, looming provider shortages, the primary care provider shortages that we didn't talk about. That's an enormous challenge, as we have to really do a lot more sophisticated discussion of how graduate medical education's handled in these kind of reforms that really direct more providers into the primary care arena, especially for vulnerable populations. So there's a lot of detail in it. And I know how bills are written, and I know why you can't get into the weeds on a lot of these things. But those are very, very important issues. And when you talk about a payment mechanism, a guaranteed payment mechanism, I see, if it's not done properly, you will see people gravitate. It's not that the wrong people will gravitate to the wrong place, but you need a robust infrastructure to take care of vulnerable populations that can't just be migrating to the usual suspects that, again, very good providers, but without those support, wraparound, community-based services. We failed to mention that we use community health workers who are from the people, of the people. So these are the concepts that are growing in this country, and we need to make sure that, and I would, my greatest wish would be a lot of these programs that are, we'll call it, and it's just a bad word, but enabling services, that they're incorporated increasingly by the private sector too. And then we'll feel better about our vulnerable populations being cared for by the traditional players. And so, I think we'll come around and talk about some of the details in these legislations where I think that there's really a lot of great opportunity.
That's a good question. So I serve homeless families, and I've been doing that for 17 years now. And I see it all the time where people, I refer people to primary care, and or people have had histories where they didn't trust their provider in the past, and they just kind of fell through the cracks, and so their health status was impacted by not having a trusting relationship, a place where they'll get wraparound services. So when we send our people to Carolyn Downs and Country Doctor, they feel welcomed, and it really has a huge impact on the population that we serve. So I didn't realize that 28 million people in the country is served by the community health centers, so that's pretty phenomenal. And so it's obvious that the system really serves this vulnerable populations and is doing a really good job in that way. But I'm kind of wondering about the difference between the Jayapal versus the Sanders bill, whether one is more favorable to the work that's been done by effective systems like the community health centers. Does anybody know that?
I looked at both of them. I'll actually take that, Dave.
Bernie's doesn't have global budgets in it, whereas Jayapal does. But my question for you is, if you didn't have to worry about any of the finances of the patients that you now see, you said 40% of them you have to bill, you are able to bill some way, and therefore there must be at least one or two people working in your office there who keep track of the bills and who to bill and all that. If you didn't have to worry about that, wouldn't that be a good thing? And as far as global budgets, I would think that all of your wraparound services that are so critical to your mission there would be included in your global budget. And there are global budgets that are hard global budgets and soft global budgets. The soft global budgets are the ones that you negotiate with the regional entity that figures out, how much to give you, and that's negotiable. But the soft global budget is that if you overshoot and spend more money that's in your global budget, you're not at financial risk for that. It's just, they give it to you, but the next time you negotiate a global budget, which may be in 6 months or a year, that's taken into account. But you don't have to say, well, we're pretty close to using up all the money we got for our global budget for the 6 months, so we have to restrict some services, and we can't send the nurse out to see somebody in their home with a HIV problem or something like that. But wouldn't that be the best of all possible worlds for you guys?
I don't want to shoot for the finance department. Maybe you want to take that.
Well, I mean, David, the best thing in the world would be if we didn't have to employ a half a dozen billing staff and coders in our finance department and 3 or 4 eligibility workers to help people sign up for insurance. So those are services that are a necessary evil today. I think the devil would be in the details in terms of how a global rate would play out. We do so much more than provide health care to individual patients. And as I think about our role training the future workforce, we have a residency program, we have medical students on site, now high school students on site. As I think about how we partner with public health to prevent diseases, whether it's breast and cervical and colon cancer screening or HIV, and when I think about just the ways we're building communities around us, we're working in schools, working in homeless shelters. I just don't want to have quantification of our work be based on and compared with other providers that are delivering individual health care, because it feels like healthcare can be so much more than that, and it is for us. It's public health, it's workforce training, it's community outreach. So it's hard to know. It could play out really well or not, and you would have to tell us.
It would be included in your global budget that you negotiate.
Yeah.
I mean,
So
yeah. I didn't
there's...
see those things in the legislation, that it was sort of what the global budget could include and not. So
Right. The language is so vague, and I understand why it is that way. And I like the idea of a global budget, but where the devil's in the details. And when you talk about a global budget, you've got this czar. There's a czar. There's a czar in the nation. There's a secretary who's in charge of the whole gig. And then there's regional administrators. We know about regional administrators. On the federal level, we're in Region 10. And the level of involvement, sometimes they're good, sometimes they're not, but they are always marching to the orders of the federal government, right? Whoever's in power at HRSA. So they take their orders, like the head of the Department of Justice takes his marching orders from the chief. It sounds good, until you have to sit down and have that negotiation. And when you read the language, yes, that's true, that Sanders doesn't get into the global budget thing, and our representative took a good crack at it. But it's so general, there are no guarantees. Actually, this is where I don't want to get cynical, and I'm not. I want to be optimistic because there's actually language of how they would approach the first year of budget negotiations and reimbursement for your services. And then there's language of how they would do ongoing budgeting for your entity based on 3 years historical budget. That's pretty good. So, I guess my answer is if that's really true, and some of this language changes that identifies us more as a central non-byproduct, I'm in. And I think that's an important point because we fight for reauthorization, right, every 3 to 5 years. And that's a massive advocacy effort, which, oh, by the way, we have a carefully thought out strategy that goes right to both sides of both parties, right? Because again, we have friends on both sides of the aisle. And at the end of the day, one of the things that just makes me nervous, if I have to articulate it, is in this area, we need to be friends with both sides. This cannot be a liberal left progressive issue because it will fail. The only way we do this is succeed as a nation and pull this off and not alienate the other side. Again, same boat, right thing to do, but also making good effective use of taxpayer dollars. So we've negotiated that role very, very well. We have great friends that sign, line up to sign on to our House and Senate reauthorization bills. And I just worry about that getting all lost in the fray of a global budget, which has to be regularly negotiated. And at the end of the day, it's at the whim of tax revenues and how much federal budget deficit we're about to tolerate. The piece, just to put a little bit of money perspective on this, because I think this is important, is all the stuff that we do. If you look at the health centers as a nation, about 20 to 25%, 22 or 3% of our funding comes from the federal government. The rest is other kinds of sources, but that's to the tune of $3.8 billion. And that's always a good number to remember the TARP, the bank bailout of $800 billion. $3 billion to make all this happen, and I worry that just won't be there. At the end of the day, negotiations happen.
I think it's really important to frame the conversation around healthcare reform, around community health centers, and also around the individual patients who are going to be affected by this, whereas the majority of the discussion is mostly around financing. Like, how much money are we going to save? Why is this costing us $32 trillion over the next 10 years? That's all that everybody is talking about, and I really like that you guys are trying to push that back. But another one point that I had was when it comes to the budgeting and negotiation of budgets, yes, we do have a Secretary of Health and Human Services who's essentially going to be the czar of budgeting, but at the same time, like, those individuals can be held much more accountable than a board member of some private insurance company in a city like Seattle or like richer areas. So I just want us to think about that as well, as that it's much easier to hold the HHS secretary to accountable, especially because they're only in office either 4 or 8 years, or possibly less. But another question that I had was that, one of the concerns with our healthcare system right now is that it's very overburdened, and a lot of the providers are overburdened. And I'm wondering, do you guys see that often in many of your clinics? And then are you concerned that if a Medicare for All system is implemented, that community health centers and primary care clinics are going to be overburdened? And is that going to drive up your costs? Are you going to have to negotiate more money for your annual budgets? Or what is your take on that?
Overburdened thing, that's why I do what I do. Sarah, do you feel overburdened? Or do you feel mission-driven and fun to go to work?
I think bring more people.
Yeah.
Hire more staff, we'll have more services.
Build more buildings.
Build more buildings, yeah, we can grow.
Yeah.
We can meet the need. We know, if one thing this country, what you have demonstrated as a movement, is we know how to scale up. We just need the resources to do it.
Yeah. You had a question.
I did. I was just thinking about last year when they kind of defunded the CHIP program. I can't remember it sort of oozed into a solution eventually, but as a school nurse, I just felt so alarmed. How does that kind of thing, how is that affecting you while the Trump administration is feeling its way along to what it can get rid of?
We were part of that same issue with CHIP. When CHIP lost its funding, we lost ours. And we had a little bit of a reprieve at our personal health center because our federal funding was a few months off cycle, so we didn't actually have an end of any funding, but some of our fellow health centers did, and we were near that brink, near that cliff.
I remember the state Medicaid was like 1 month away from losing it all. And then January came and I think the Congress did something.
And to me, it's just one more perfect example of why universal coverage, Medicare for all, would be great if we wouldn't have to deal with those sort of annual or every 5-year cliffs, and if we didn't have to deal with it. It's perfect that I came here today because I spent 2 hours this afternoon talking with our lawyers about an issue that we're having with an insurance company. Okay, so I'm just saying, I'm primed for this, and there's a lot of things that I could easily get rid of from my job, and negotiating and bringing in lawyers in issues with insurance companies is one of them. So,
And it's interesting that you bring up the SCHIP program, that's our state child health insurance program, because that kind of gave me the jeebies when I read Bernie's bill, and you actually see this thing that says day one, when this goes into effect, we cut off arguably the greatest achievement of the Great Society, right? That we fought hard for Medicare, Medicaid, and SCHIP, and they're gone. Day one, as soon as it's enacted, those are brought. That's scary for an untested future, and you won't. And believe you know this. Once that's gone, you ain't getting it back. So again, it's just another level of uncertainty without a real transition plan. But when you read those words in those bills that say Titles 18 and 19 are dismissed, they're precious American traditions. We can't afford that. I mean, if it all goes well, you might, but that's really betting the farm.
Kathleen, right?
Yes. But what about ACOs? What about the hospitals purchasing all of the community individual providers of services and then aligning them into their huge hospital conglomerations? How do you feel about that, and how do you see that being affected? Because I think that is where the global budgeting is going to strike rather than at your organization, which is more of a primary level organization.
I just got to say, so I get it off my chest. Dave said I could even swear here, which I won't. But that's putting God in charge, right? With all the intrusions that would come with that when we talk about the Sisters of Providence in charge. It's their global budget that tell us what we can and cannot do. That's pretty scary stuff, right? And we see where the future is going with faith-based organizations running major hospital systems. So that should give all of us a pause, and it certainly would give any of us in the health center movement the motivation to fight that. Is that true?
Now, I worked at Children's as well, so how do you see the teaching hospitals being affected?
Other than being pretty inefficient and huge consumers of resource that don't necessarily get the best bang for the buck, I think we need to protect it. I mean, we've shown that. We need to control where people are where the workforce is going, where it's needed, rather than having people have freedom of choice into specialties and things like that. But you don't want to see them harmed, but they need to be held accountable too. But they are not, again, they are not community-based organizations, teaching hospitals. There's no meaningful community input into the way they're operated. There's an advisory board for Children's Hospital, but you will never find any incursion into operations.
My biggest challenge with, go ahead.
So We're spending 18% of our GNP on healthcare. Incredible waste of money. Our health outcomes are not anywhere near where they should be, spending more than any other country in the world. I just wonder how we take that into account and realize we have to change the way the money is distributed. There's no way to get around money, and there needs to be a better way of managing our healthcare budget. That's one question. The other question I have is, are community health clinics all over the country? Because there are many states that don't have Medicare. There are many states that don't have provisions for people who are out of the system. And I'm concerned about those states and those people, and how are you going to take care of them? And does Medicare for all need to be community health clinics for all? Is that what we're moving toward? Why not have wraparound services for Bellevue and Mercer Island? And, you know, why not be grandiose in your plan? Why be limited?
So my grandiose plan would not be Medicare for all. It would be Medicaid for all. Medicaid is, for the people that we work with, an incredibly comprehensive and effective way of currently paying for and organizing healthcare. Of course, there are a lot of similarities, Medicaid, Medicare, but Medicaid works for low-income people in a lot of ways.
Let me give you a line to carry with you, because this is my operant principle. You know what anyone with, I'm sorry. You know what anybody in the private sector talks about Medicaid. It's a very disparaging, insulting thing. I am here to tell you that in the community health centers, the federal Medicaid program is nothing short than a fair, reasonable, consistent, and cost-effective partner in the care of our communities. So are we on different planets or what? That I can say that, but you know, every other system's doing what they can to get rid of the Medicaid rolls on their books. So that's a pretty profound thing. So we can't back down. We cannot back down. It's too important a fight for that, 10% of the people, 15% of the people that are incredibly vulnerable in this country. And I'm willing to hold it hostage. I mean, no one's going to ask me, but I'm willing to hold it hostage until those are properly codified in the law, and that's where our representative has an opportunity to take it up to another level.
But there's, millions of people out there that have Medicaid and they can't find a doctor to take care of them. So that's a huge problem. So maybe Medicaid works for a country doctor, but not for a vast number of people across the country who have it and can't find somebody to take care of them.
Or don't have
The other thing is, for long-term care services, in Medicaid, you got to spend down before, the government will take care of you. So people, they're saving money for their kids, or they don't force you to sell your house, but after you pass away, they can force you to sell your house. So that's a terrible thing, and it probably affects people at country doctor too, doesn't it?
Definitely.
You're absolutely right. I mean, it's really unfair for me to have just gotten on the high horse here without saying that Medicaid is all fine and good, but you really got to be dirt poor to get it.
Yeah.
So that's really wrong. But that can be changed, right? That's just a numbers issue where you set the level of poverty. Remember what happened with the Affordable Care Act? We went from states that were as low as 18% of the federal poverty level to get Medicaid, like in the Deep South, to Alaska. You're already at 140% of the federal Medicaid. It was at the whim of different states. It's crazy. In that at least some semblance of uniformity came about with the Affordable Care Act. Though you're right, it's just shy of 30 states that have eligibility that expanded Medicaid, and you're woe to the people who aren't in one of those states. They cross state lines and get their care where they can.
My understanding was that Medicaid is administered by insurance companies, and they take up to 40% of the funds for their administration. Is that a wrong impression?
That's probably a very correct impression, and that's not a part of Medicaid that we enjoy or appreciate. But it's similar to Medicare Advantage. It's the privatization of a government program in the way that people on Medicare can currently buy private plans. that isn't something that we would stand by.
Yeah. Medicare Advantage is 17 to 20% is what I understood. And Medicaid, I was just shocked to be told that it's 40%. And it just makes me sick how many billions of dollars are going to profit and waste. That really worries me.
So we don't know those numbers. In our state, in case anyone doesn't know that, our Medicaid is managed, it's basically managed. And there are 5 entities that you've heard all the names. One of them is a nonprofit, the other 4 are out-of-state for-profit institutions just fighting for market share and doing what they can to, skim whatever they're going to do. It's nothing we support, but that's the devil we have to play with.
But we believe in the nonprofit, and it's a close partner to us, Community Health Plan, and I serve on the board of it.
Jonathan from Molina was down testifying at the legislature for 5822, that pathway to universal health, which, by the way, died this afternoon. It's not like, Molina's not nonprofit, is it?
No. It's very much for-profit.
Yes, but they've been a better administrator as far as I could see from the birth unit work. They gave more benefits, and so they weren't cutthroat, horrible people, and he's pushing for a better system. So
They're not horrible people, they're just beholden to a shareholder, and they need to make a profit, and they need to pay a CEO. So you're absolutely right, there's where the money is. It's billing, it's these managed care organizations, but we actually work mostly with the nonprofit one that I actually helped start. And the whole principle, I was at that table, was we need to make a profit off of Medicaid so that we can take care of the uninsured.
About the Medicaid stuff. I'm a registered nurse and I work in my local rural hospital in Arlington. And for many, we just always have 2 to 4 elderly people just in a bed waiting to try to go for placement. And their Medicaid payment is so low, they just stay with us for 2 to 4 months, sometimes longer, waiting for some adult family home or, usually it's an adult family home to finally accept them. And so I'm just surprised that I would love to have you be the example to the nation on how you can provide care to everybody with the Medicaid reimbursement. But here rurally, I don't see it happening. The providers just don't seem to be able to make it on that kind of reimbursement.
Oh, very much agreed.
And I apologize.
Yeah, very much
I only
agreed.
got like part of everything you said.
We'll hold the microphone closer for the last bit. Our experience at Country Doctor with Medicaid is related to primary care, but boy, the shortfalls when it comes to specialty care, when it comes to long-term care, nursing home, adult family home, are real. And even with our primary care patients, it's very difficult for patients that we serve on Medicaid, and we serve them ably, but when they need a specialist, or they need institutional care or behavioral health, the challenges get much steeper. So I totally agree with what you're saying. I think my comment about Medicaid for All is thinking about our level at the primary care side.
Absolutely.
So, but your point is 100% well taken.
Oh, okay.
And to be fair, again, I was again, on my high horse about the fair, reasonable partner. That's because by federal statute, community health centers are paid pretty close to their cost of providing the care. And it's actually it's arithmetic again. It costs us this much to provide the care. We have this many patients, X over Y, and that's what we get reimbursed, and it's recalculated every year. And that's our reimbursement. The reason behind that methodology was to keep the federal Medicaid program from eating away at the federal grant dollars to the uninsured. So that's the logic behind that. But I have plenty of friends who work in the private sector, even primary care. I know what their reimbursement is, and it's low. It's like a third of what they get from the private sector. So I'm not trying to vilify anyone. The way they've set up their world, you can't make ends meet on that. And somewhere it needs to meet in the middle. But if it's a zero-sum game, we don't want to be the Peter who's robbed to pay Paul. That was a good one.
Yeah. My challenge with the global rate in Medicare for All is that when I talk to David McClanahan, I suddenly feel okay. And I think David explains, hey, it's going to be like your current Medicaid cost rate that Rich was just describing. And I think what would help me is in the next iteration of the legislation, if the global rate is still the mechanism by which community health centers, federally qualified health centers, are paid, I would love to see a stronger statement about why and about what that payment is intended to achieve and what it's for. And is the global rate a recognition of somehow we're problematic people that cost more because we're serving low-income people? Or is it that we are really we're a source of innovation, we're a source of training the future workforce, we're a source of both primary care and public health, and we're saving the system dollars. So by investing more through a global rate, we'll save the overall system. So it's the why part and the purpose of the global rate that I didn't see in the legislation. But when I talk to you, David, I suddenly feel okay, but I'd like to see it in writing.
I think that's really true. I was looking, again, when I was looking at some of the details here, I was struck by Representative Jayapal's in 1384. You know, there were things, if I would call our attention, if we have to rework this, to 402, 403, and 404 next iteration, if needed, and 611. 402 is about consultation with shareholders, and that's what kind of bugged me a little bit. That was the section that had shareholders, and in parentheses there were like 3 or 4 listed, and then it said FQHCs and a couple more, and it was like, that was it. That was the recognition of this entire effort in section 402, consultation. I thought that's got to change. And I'll tell you why it's got to change in a second. But the other one that I mentioned, the concerns about regional administrators, because they come and go, and I think that's a good point about being held accountable. But our patients don't have 4 or 8 years in an election cycle to be held hostage or accountable. And then the one I also thought was an opportunity was section 404 of the Representative's bill, and that was the ombudsman. And ombudsmen are very important entities to guarantee the rights and the right to protest, the basic American principle. But the way that was listed was it's going to be an ombudsman for George or Mary who's having a problem getting the services they need. You call the ombudsman. I think the safety net needs an ombudsman to be able to deal directly with the federal government to say, hey, this is working, it's not working on behalf of the system. We have a national organization that could work directly to make that happen. So I think there's kind of language to call out this system, and I'm not trying to minimize the importance of the VA system or the health department system in this country. They're all vitally important, all hands on deck. But we have to speak for ourselves. And at the end of the day, I mentioned this to Raleigh, you were talking the other day, is we have a patient majority board of directors. We did the math, and I don't know, I thought I heard 70,000 nationwide, but it's probably more like 35,000 patient board members sit on the safety net. When you want to start talking about, and they are all active, they all are encouraged and facilitated to be politically active and contact their elected representatives. That is the kind of lobbying base that needs to be reassured and then mobilized. When those guarantees are in place, Raleigh will be the first one to line up our board to be harassing our representatives to make sure that they make this happen. So this is just a language thing to acknowledge where care is being delivered for the most vulnerable people in this country, create the guarantees that they're not going to lose the resources and those enabling services that they have, and then we can all work towards this. So again, that's not without even mentioning the total number of workforce in these 11,000 centers around the country. That's a lot of advocacy if we can be reassured.
Just thinking of the sections of the bill, section 611 about the global rate, I think this is the place to do what Rich is talking about. In section 611, the global rate lists those eligible for it, hospitals, FQHCs, others. I would love to see a section, 611A, that's about federally qualified health centers and the opportunity they provide and the rate for training, the rate for public health, the rate for patient care, the rate for innovation. And the global rate itself is probably fine, like David tells me, but kind of the why part would be more to my liking. How can we describe the benefit of that global rate for health centers and what will contribute in the new model?
I'd like to kind of sort of step back for a moment and take a more overall look at this. I've always viewed Medicare for All or any kind of a national government-run healthcare system as an opportunity by centralizing the funding for it, that all of our tax money goes into it. We can create a platform upon which we can start to improve the various things that go on in the delivery system, because there are problems everywhere of all sorts. And you guys are illustrating one area, which is the safety net. Now, if you go to England or to France or to Germany or to the Scandinavian countries, they don't talk about safety nets. Why? Okay? Because everybody has care. You're human, you're here, you get care.
They also have guaranteed incomes and housing.
Well, yes, and the other thing that you bring up, which was my next comment, which is the European countries spend more on social services of various kinds than they spend on health care. And you're proving that when you spend money on the social services, you don't need as much for health care. But we aren't going to be able to get there if we don't get control of the whole ball of wax and create that platform upon which we can say, now what works? Community centers work. Community centers show us how combining social services with medical care for at-risk populations, because European countries have at-risk populations too, and they manage them in a more not global in the sense of global budget, but in a more global way in the sense that it's built in to their overall social system of which healthcare is a part. And it's going to be a big transition for this country if we can get there in my lifetime, because there's so much money being made by treating healthcare as a commodity to sell for profit. And we need to, there's going to be change involved in removing the profiteers and in doing what we need to do that works. So I think your voice is very important, but don't make it a negative voice about getting going on change. Just that we have a particular piece that needs to be paid attention to as we do this.
Thank you. And just looping back to our vision that there is universal health care and we're the provider of choice, we're right with you. We share this vision.
Because what was important when Raleigh says we're the provider of choice, we're not the provider of choice because people are regulated to see us. We're just the best, we're the best quality option that they can find.
Right, then people can compete on the basis of quality of care.
Absolutely.
Rather than on what's going to make us the most money.
Absolutely. I do have to say, I shudder a little bit when we get vilified compared to every other country. I think that's not productive language. We're the only country in the world that doesn't this, that, and the next thing. You've all traveled in even developed world, developed countries where they have a universal health care and anyone can afford it, goes and buys other care so that they can see the specialist that they want and they can get enhanced care. It's a problem. And the world needs to acknowledge that. We don't control it. It happens in I can't speak for Scandinavia. Every other country in the world has a two-tiered healthcare system. So it's just too disempowering to always rag it on ourselves when everyone's got the disease.
No matter what, the very rich are going to get what they want, where they want it, when they want it, no matter what. So just disregard the very rich. It's everybody else, from the merely rich on down.
Yeah.
And they use their country's universal healthcare systems, all of which are vary. Not all of them are single payer. A lot of them have various kinds of input and out-of-pocket expenses, but they all function better than ours does.
Margaret Flowers has been sending us studies to make us feel good about what we're pushing for. And she had a study that she reported on that compared Canadian people in poverty compared to U.S. people in poverty who came down with cancer. And there was marked differences in how those people fared, how long they lived. There was marked differences, and it was the poor people in Canada did 35% better than the poor people here.
I've had the privilege of working for doctors in offices, for specialists, at Children's, at Overlake, worked for Northwest in a multifaceted clinic. And so the things that really bother me are that we have to have huge charity fundraisers to raise money to care for kids, that we have to have huge buildings and these megalopolies of conglomerations of different kinds of care coming together. It should be a simpler process. And if we had a simpler process, it would be easier for somebody in a rural area like Arlington to have a hospital that also had the long-term care that's in the health care for all bill, to just have a wing, so we've got some patients that are going to be in this wing for a while, and if we can get them into assisted living later, we can do that. No big deal, we just manage the level of care that they need in the meantime. And it should be a fluid sort of thing that kind of goes back and forth between primary care, maybe somebody coming out to the home every once in a while to check up on patients who have chronic conditions that are not mobile, but they don't really need to be managed in a facility possibly. But we just need to have a better system. I've seen it work so much nicer. When I was in California, the doctor I worked for, I finally talked him into let's just not take Medicaid. We won't take Medicaid. Let's just ask people what they can afford to pay and let them pay what they can afford. We'll provide the care. If they have to go into a hospital, then they can use their Medicaid. But it saved us a billing nightmare to get authorizations and approvals and all the foolishness, and then to get paid $5.40 for an office visit. People came in and put down their $2, $3, $5, whatever they felt they could afford, and they walked in with dignity, and they walked out with dignity, and they felt really good about paying whatever they could and getting the care that they needed. And when you see that, it really helps you to understand how it diminishes us, to stratify us the way that we have been stratified. We need to be integrated much more genuinely.
I'll just say, if any of you in this room would ever like to come and pay a visit to Carolyn Downs Clinic on Yesler or Country Doctor Clinic on 19th, we'd be more than happy to see you there. And if you're feeling any aches and pains right now, as I said, we have the after-hours walk-in clinic just in this building that's open for another hour tonight. But we'd love to stay in touch, and if there's anything we can do to help the cause, I think we're with you on the long-term vision for sure. So thank you.
When's your next fundraiser?
Good. So we're still in that place where we have to raise money, but we're not raising money for the day-to-day care we provide. We're in a fortunate position that for an average visit like Rich provides to a patient, we can usually find payment and we can get some sources to help with uninsured. when we raise money, we're raising money for that innovation I was talking about. We're raising money for the exciting programs like the prison reentry program that are helping people when they get out of care, or our substance use programs, or our homeless outreach programs. And we have a big dinner every fall. It's in September, October. I'll make sure that David knows about it. And I think you're going to host a table this year, David, aren't you, with your friends? So,
One of many.
yeah. And like Rich said, many, many people on our board are very sympathetic toward Medicare for All. And our board chair spoke at the public meeting a Saturday or two ago. And so there are a lot of people with you in spirit. Thank you for what you do.
Thank you.
It's awesome. I couldn't end it any better than the words that you used. And I think it's important. I think I probably may have sounded a little antagonistic. I'm not. I'm just protective of our network. And I truly don't believe there are bad providers, except for a few people. Providers are doing the best they can with a crazy, insane system. And we just need to give them the freedom to do what they were trained to do, and their hearts are. So that this will get there. This will get there. And if any of you are in a position where you're asked about language of this, in the next iteration, we would be more than happy to suggest protective language.
We made a start right here.
That's my notes on the bill.
We have one more question online.
Earlier, they talked about that a lot of their funding or a lot of their budget comes from grants. And David had asked about how much time is spent in billing for the people at insurance, but is there quite a lot of time spent on applying for grants? Or once you get them, are they pretty much set? You don't have to worry about them so much?
Very good point. And we're working on 3 grants right now. So do you see these bags under my eyes as we try to get them out the door? But I'll say that the difference for me is that when we're coding charts and billing insurance plans, that work is all annoying and non-productive. When we're writing grants, one of the exciting things is that we get to focus on exciting opportunities. We get to think about how this grant can help transform our work. So personally, writing grants kind of energizes me, but it does take time to manage it and have all the staff that do the finances around the grant. So your point is well taken. But I would say my biggest concern is the amount of time that gets sunk into managing our relationships with insurance plans and all the billing there. That's what I'd love to get rid of.
Just to reiterate that, the grant process is always interesting. Again, it's a pain in the neck, but it identifies a problem in our community that we know, our board acknowledges is a problem, whether it's chemical dependency, whether it's hepatitis C, HIV, any number of problems, our mental health access. And they identify the problem, they direct our staff to deal with it, find something. And then we have to do the homework, we have to do the public health background work, figure out a response, create quality measures, set benchmarks, and hold ourselves accountable to achieving those benchmarks. That's important work. It's a real nuisance, and there's some level that you'd like to be just written a check and let us just get on with it. But I think we agree to be held accountable for it, and I think that's part of the deal, the equation of accepting public support.
Well, I have a last comment that I think that you two guys should have a face-to-face with Pramila Jayapal. I think she'd be very happy to listen to your concerns, and you might invite another similar clinic leadership around to, say, 4 or 5 people and spend 45 minutes with her in her office. I think she'd be very glad to hear your concerns.
We'd be glad to have her up to visit the clinic as well.
Patients too.
And she just started her congressional recess on the 15th, so she's home.
Okay, great. Thank you.
Anyway, it's been wonderful having you two guys here, and it gives us all some things to think about. And I'm glad we got this on video. We'll put it on YouTube in the next day or two with some subheadings, hopefully, that so people can just click on certain topics.
I'd like to say thank you so much for your work. I can't imagine what our region would be without you.
I mean, I think the important principle is we are your community health center, right? These are our neighborhoods, these are our neighbors, this is us. It's all of us, right? And it's your health center. You want to bend the curve even more, just get on our board.
How about you getting on ours?
It's a thought.
It is a thought, and it's a thought that I think is a voice that we need to hear from. And so if you want to recommend somebody, I think we'd be delighted to have the community health arena.
Good.
She's let Sally back in the room.
Good.
That's great.
Good. Well, we'll get there. We just have to keep working on it. So thank you for what you do.
Thanks.
Okay.